Queued up here. All right, can everyone hear me and see my slide?
We can.
Okay, and the next test is, does my slide advance?
It did.
Okay, great. All right, so thank you very much for having us today. I love talking about this topic, so please feel free to interrupt if you have any questions. I'm happy to divert and answer what you guys need to know to take care of these patients out in the real world. So just the basics to start, a left ventricular assist device, or LVAD. It's a small surgically implanted pump. We use it when the left ventricle is weak and cannot pump the blood it needs to the body. We use it as an advanced therapy for end-stage heart failure. So that's patients with New York Heart Association class 3B to 4 symptoms and an EF of less than 25%. And just as a reminder, what class 3 to 4 symptoms are for heart failure. So those are people who have shortness of breath, fatigue, palpitations, or chest pain with less than ordinary physical activity is the class 3. And then class 4 is those same symptoms, but if they occur at rest. And we know that unfortunately there are some new medicines out there for heart failure, but even with medical therapy, heart failure has a terrible survival statistic. At 2 years for people with advanced heart failure on medical therapy, their survival is only 53%. And then it gets even worse for people with advanced heart failure who've had one or more heart failure hospitalization. For those people, their survival is 47% at 1 year. So pretty dismal statistics there. So we're happy that we have a therapy that can help these people with advanced heart failure. So here at Maine Med, which is the only LVAD center in the state of Maine, we implant the HeartMate 3 LVAD, which is an Abbott product. And it comes with a 1A class strong recommendation for patients with class 4 symptoms who are dependent on inotropes or temporary mechanical circulatory support, and then a moderate 2A recommendation for people with class 4 symptoms who are symptomatic despite the medical therapy we have available. So basically that means that the benefits far outweigh the risks of these devices. And here you can see the HeartMate 3, which again is the pump we implant and is the most up-to-date pump on the market. 2-year survival for our HeartMate 3 patients, 83%, which is significantly higher than the statistics I just showed. And then we just got some new data out in the Momentum 3 trial, which was a follow-up study at 5 years of HeartMate 3 data. And they are with a 5-year survival of nearly 60% of people with the HeartMate 3. So that's excellent. This is just a little graphic of our program. So we've been implanting LVADs here at Maine Med since 2014. The history of our program, we've implanted 114 patients. In the beginnings of our program, we were using the HeartMate 2, which was just the older version of the HeartMate 3. It's significantly updated since the HeartMate 2. But you can see those are the gray bars there in the beginning. There was a brief period of time in 2017, 2018, where we were implanting a Heartware product, which was a Medtronic product. This pump has been taken off the market. It was shown to have a higher risk of stroke. And so it is no longer being implanted anywhere in the United States, and we have not implanted them here at Maine Med since 2018. We currently manage 41 patients in our program. There's probably a couple more patients in the state of Maine that are possibly managed by the Boston programs that we might not know about, but we have 41 patients in the state of Maine currently. All of those are HeartMate 3 patients, except for one heartwear patient. We do have one heartwear patient still with that device. We saw him in clinic today. He's doing pretty well. And he will live the duration of his life with that pump. It's not something that we would explant, but it's not being implanted anymore. And we lost our last HeartMate 2 patient probably about a year ago, but there are probably some HeartMate 2 patients out there in the United States, just not in our program currently. So this is what the HeartMate 3 LVAD looks like. It's a pretty fascinating technology. It is a centrifugal flow pump, which is different from the HeartMate 2. And it is a magnetically levitated rotor. So it has no mechanical bearings. And why this is important is it reduces shear on the blood. So in the end, that reduces the patient's risk for stroke. So this particular pump has very excellent numbers of strokes associated with it, low numbers. So we use this technology for 3 different reasons. We have some patients who are what we call bridge to transplant. These are patients that are candidates for heart transplant and are on the wait list. So patients can unfortunately wait years for a heart. And so we can use this technology to get them to transplant. Then we have our destination or chronic therapy patients. These are people who possibly don't want a heart transplant or don't qualify for a heart transplant for some other reason. And so then they will live the duration of their life with an LVAD. And then the last group of patients are bridge to recovery patients. So the ventricle can recover. The LVAD helps offload the heart, and so the heart muscle can recover. Nationwide, this is less than 1% of our patients are a bridge to recovery. Maine Med has had some excellent success with bridge to recovery. We've actually explanted 7 patients over the course of our program, so that's about 6%. So we're well above the national average on that. Although the average is less than 1%, certain groups of patients are much more likely to recover. For example, a patient that has a cardiomyopathy from a reversible cause, so such as like an alcoholic cardiomyopathy. If they stop drinking and are on LVAD therapy, the ventricle could potentially recover, and then we can explant them, and then they can live a healthy life. But something like ischemic cardiomyopathy is a lot less likely to recover. So when we evaluate someone for LVAD, it's a very extensive evaluation. We are an adult program, so we only evaluate patients 18 years up. We currently have, our youngest patient is 20, and our oldest is 81 years old. He was implanted, I think, at about 74. We don't have a top age where we turn people away. It's more a matter of they have to be a pretty robust, mid 70-year-old for us to consider them for LVAD therapy. And so they're going to meet our whole team. They meet our coordinators, they meet the surgeon, social work. They have to have a full evaluation by psychiatry, palliative care, physical and occupational therapy. They go through right heart cath, left heart cath, lots of imaging studies, lots of blood tests. Basically, we just want to make sure all their other organ systems are healthy enough to support the pump. Particularly the right side of the heart. So as in its name, the left ventricular assist device only assists the left side of the heart. So the right side of the heart still needs to be strong enough to do its job and get the blood to the pump on the left side. So we do lots of testing to evaluate for right heart failure to ensure that they will be successful after implant. So life with an LVAD, I didn't talk about quality of life metrics, but we do measure those. We want people to not only survive, but we want them to get back to their regular life. And so there are quality of life metrics that we follow, and people do well on these devices. I think it's hard sometimes, especially for your pre-hospital folks. You only see these people when they're having a medical crisis and they're not doing well. But we implant these pumps so that people can go out and live their life and get back to the things that they love. So, we have people that are out golfing, people that are hiking. There's some absolute contraindications that you can't do. You can't swim or be immersed in water. There's some activities like welding you can't do, no contact sports and that kind of stuff. But we do try to get people back to work, back to doing the things that they want to do in life. I don't know, we've had people, we have a DJ at a nightclub. We have a young woman, peripartum cardiomyopathy, who was bridged to transplant. She raised her infant daughter on LVAD therapy and went back to school and got her master's degree. So people are doing really great things on LVAD therapy, but it does come with some trade-offs. You have to have frequent appointments. We see our patients once a week initially, and at a minimum every 3 months once they've been out for a while and are doing well. They have to be in communication with us all the time. They go for lab work, usually weekly. They all have to be anticoagulated with warfarin. There are no studies right now on the newer anticoagulants, so we are using warfarin on all our patients. So that comes with the frequent blood testing. They always have to be connected to a power source. As you guys know, I'll show the equipment here next, but they're connected to batteries during the day when they're up moving around, and then at night they're connected to AC power. They have a drive line that exits their abdomen, and that has to be covered with a sterile dressing. So we have to teach a friend or a family member to do that sterile dressing change for them. Initially, that's once a day. Eventually, it goes to once a week. They have to travel with emergency equipment, a backup controller, backup batteries, clips. And then there's always risk for rehospitalization. Most of our patients do end up back in the hospital at least once in the first year for some kind of complication. Not all, but it does happen as far as bleeding or infection. And then there's a reliance on caregiver for support. So all our patients do have to identify a primary caregiver, somebody that can initially drive them to appointments, can help them with their medications, can do their driveline change for them. And we do require that they have a caregiver with them 24 hours a day for the first 30 days that they're home. After that, they can be more independent. We do have people who live independently, but not initially. And avoiding water sources and dirt because of infection, particularly like a pseudomonal infection in water can be a big deal. So people can eventually shower, but we have to give them special equipment. We have to give them special training. So people are not showering usually for about 3 months after they get the pump and are home. So system components, this is what it looks like here. So we've got the pocket controller, which is sort of the brains of the operation. That's connected to 2 batteries, or at night, the mobile power unit that you see down there in the corner. And the pump itself, and then the modular driveline. So the new HeartMate 3, the driveline itself is two pieces. So there's a piece that's connected to the pump internally and is tunneled through the under the skin and comes out through the abdomen. And then there's a connection that then goes to the controller. So if we have damage to the driveline between that connection and the controller, we can exchange that modular piece, which is an improvement. Previously, it was all one piece. So if there was significant damage to that line, it required a full pump exchange, which is back to the OR for open heart surgery. So now we can exchange that modular cable, which is a great improvement. The pocket controller you see there, it does have a backup battery. And so it will, if we don't recommend this, but if the patient disconnects both batteries or both power cords, they will get a very loud screeching alarm. But the pump does not automatically stop. There's about 15 minutes of power in that controller. And it's an about because every patient is running at a different speed. So the higher speed, the more power it's going to pull and the less that battery will run. But approximately 15 minutes, they have to find a new power source or change their batteries or whatever they need to do. But if that backup battery does die after the 15 minutes, the pump will stop. Questions so far?
Pretty straightforward, though I'll ask a question. Why can't I weld?
So it has to do with static electricity, I believe. They've had some problems where static electricity causes a pump stop, so they can't weld because of that.
Excellent. That seemed highly specific, so I wanted to know.
Yeah. I've never had anyone test it, but they tell us in the book and not let people weld.
Excellent. Thank you.
Yeah. So the biggest questions I get about that for people who don't care for them often are about heart rate, blood pressure, and CPR or chest compression. So we'll address all of those today. So heart rate or palpating a pulse. So traditionally, with these devices, you've not been able to palpate a pulse. So with the HeartMate 3, it does have a kind of an artificial pulse built into it. The pump automatically speeds up and slows down every 2 seconds. It's designed that way to wash the pump out and reduce stasis and therefore reduce the risk of clot. And because of that artificial pulse, it may be more likely that you're going to get a pulse with these HeartMate 3 patients. Additionally, there are patient factors that you may have a pulse or you may not. So, patients have different levels of underlying heart function, and you could have somebody who's maybe recovered their heart function. So if you have a patient with a higher EF and that ventricle is still squeezing and opening the aortic valve, then you are going to have a pulse. But if you have a patient that the VAD is doing all of the work and the aortic valve is closed, then you're not going to feel a pulse. So therefore, your pulse ox is going to be a lot less reliable. And you can hear heart sounds most of the time. It's a little tricky, but if you put your stethoscope to the chest, you can auscultate an apical pulse. You'll hear the pump. It's a really good way of knowing that the pump is definitely on is by listening to the chest because it's a very distinctive sound and you will know that it's on. But you can hear heart sounds sort of around that sound. And as far as blood pressure, the automatic cuff, I found with the HeartMate 3, many of our patients, you will be able to get a blood pressure with the automatic cuff. But some you will not. We do manage our VADs for a MAP of 60 to 80. So that's a pretty low blood pressure. And the reason that we, put them on medications to get their MAP 60 to 80 is because these pumps are very afterload sensitive. So we say they're preload dependent and afterload sensitive. So that makes sense, right? They have to have blood getting to the pump for the pump to work. And then it also has to have a minimal amount of pressure that it's pushing up against. So you can think of like trying to get water through a hose. If you're kinking the hose, it's going to be a lot harder to push that water through. So we do run our patients with a MAP of 60 to 80. So as far as my suggestions for when you're sitting with a patient, you're trying to get a blood pressure, I would start with an auto cuff. So get an auto cuff, see what you get. Does it make sense? So, if you're getting a MAP between 60 and 80, you could probably stop there. If you're not getting anything for the auto cuff, or it's a wonky reading and you don't trust it, if you have the equipment in the pre-hospital setting, you can do a Doppler reading. So the way you do this would you take a manual blood pressure cuff, put it on the arm, inflate it over 120, and then use the Doppler as you deflate the deflate the blood pressure cuff, and listen for the first sound. So the first arterial flow, when it becomes audible, that would be your MAP. So if the first time you hear it is 68, then your MAP is 68. To make it even trickier, sometimes when people are pulsatile, so in this case, the patient probably would have an auto cuff, so you may not even get here, but that first sound sometimes is a systolic. So if you do a blood pressure and it's 120 over 80, and then you do a Doppler just for kicks, and you get 120 and you think, wow, that's high, you probably picked up on your systolic pressure and not the MAP. So we like to have both Doppler and automatic blood pressure cuff pressures, but we can get that at the hospital if it's not possible to do in the field. And like everything else in medicine, you want to focus on what the patient looks like and not get too focused on the pump or the MAP or that kind of thing. You guys know what a patient looks like when they don't have a blood pressure, right? So, if you're not able to get a blood pressure and the patient is sitting up, talking to you, mentating, answering your questions, is warm, pink, and dry, you've got a blood pressure. So we can figure out the details when they get to us. But so try to focus on more of what the patient looks like in front of you rather than, getting too focused on the pump and the details of the pump. And utilize the caregivers. So the caregivers get extensive training. We teach them all about alarms. We teach them about pump function. Granted, you're seeing them when everybody is super stressed, but the caregiver should be able to help you if you have a question about equipment or an alarm or any of those things. They should be able to help you. And we'll give you our number later in this presentation. We have somebody 24/7 who will answer the phone and answer your questions.
Lauren.
Yeah.
There were two questions that popped up in the chat.
Yeah.
One of them was, and this might be way past us, but do radio frequency energy creates magnetic or static charge have an impact on these? If the welding stuff does, might radio waves have an effect?
I've never heard that they do. I would say no.
Okay.
The company is pretty good about, telling us what we can and can't do. So I would think that we would have gotten some sort of advisory if there was a problem.
Perfect. And the other one was, how accurate is a blood pressure if they're able to get one, and would a manual be more accurate than the cycling pressures?
So often we use automated cuffs. So it's probably accurate if it makes sense. So, if you get it and the map is, in that 60-80 range, and that's, your patient looks pretty good, it may be pretty accurate. Often if we're getting automated cuffs in the hospital, we'll follow that, and then only use the Doppler if we need to. So I would say it depends on the patient. But they can be. You just kind of have to put all the pieces together.
Excellent. Like all things in medicine, it depends.
Yeah, exactly. Yeah.
Thank you.
I'll be super evasive about that one. Depends on the patient. All right, so let's see more stuff about physical assessment. I already mentioned that a really great way of knowing if the pump is running is putting your stethoscope on the chest and listening. I think we'll see a picture of the controller later, but there is a little green arrow on the front of the controller. And if that's green, it's running. But the other way you can look is to listen for that hum. And there's, utilize other methods other than your vital signs to assess perfusion. So mental status, skin color and temperature, that kind of stuff. And most of the time when you see these patients, they're going to be having a problem that has nothing to do with their pump. So the good part about that is that's what you guys do and are great at. So, they're going to have, whatever they're having, bleeding or whatever. You guys know how to treat that. It doesn't really change just because they have a pump. Actually, you're better off because they have built-in mechanical circulatory support to help you get them to the hospital. So do your normal assessment, assess for bleeding. These patients, like I said, are on anticoagulation. So they're more prone to bleeding. They are prone to develop AVMs in their GI tract. So unfortunately, GI bleeding is still one of the major complications that we see. So if the patient is looking hypovolemic, acting hypovolemic, talk to them about if they're having dark tarry stools, if they're having bright red blood in their bowel movements, that kind of stuff, vomiting, coffee grounds, etc. Do a quick check of equipment and driveline when you first see them, make sure the driveline is not being pulled, the equipment stays close to the patient's body during transport. And like I said before, the caregivers are really good at this, so utilize your caregivers to help you. We'll talk a little bit more about EKG in a minute, but you're definitely going to see artifact on your EKG, which can make it very challenging to figure out what rhythm they're in. But despite that, we do recommend that you still get EKGs because arrhythmias are very common as well. And the VAD parameters, Jackie's going to talk a lot more about those in a minute, and how to get them. But if you're able to get the VAD parameters, so the numbers off the controller, it can help us determine an initial plan of care if you're chatting with us. So a little more about EKGs. So the top left here is just sort of this is actually a pretty decent EKG for our VAD patients, but you can see the significant artifact in some of the leads there. But often it'll be even worse than that. And I can't tell you why some patients are much worse than others, but some patients will just have a ton of artifact. It'll be really challenging to see the underlying rhythm, but nonetheless, give it a try. Sometimes it helps moving the leads like a little bit further away, like down their arms or their legs. But at any rate, sometimes it's just there and there's nothing you can do about it. But the reason it's important to get it anyways is because these patients can be in some pretty horrible arrhythmias and be sitting up and talking to you. So the EKG on the right there is VFib, and this was an actual EKG from one of our patients who was alert and talking and sitting up and looking great. And same thing with that slow VT down at the bottom there. And again, this person was completely wide awake. The VT person didn't even know he was in it. He had no symptoms. So The reason they can tolerate these arrhythmias is because they have built-in cardiac output. So the pump is still moving blood through, whereas normally the heart would be quivering and not giving the person any blood. So they have that built-in blood flow so they can tolerate these arrhythmias. However, we don't want to leave them in these arrhythmias forever, because eventually the right side of the heart will get tired and won't be able to do its job. So then they'll go into a right heart failure looking picture, so heart failure symptoms essentially, and eventually will do poorly if they were not to come out of these rhythms. So we do try to get people out of these lethal arrhythmias. This is just some examples of what our driveline would look like. So an completely exposed one there on the left. They should always have a dressing over the top of their driveline. It's a sterile dressing. The middle picture is our weekly dressing kit. So if somebody's changing it once a week, it's going to look more like that. That's when the driveline's a little bit more healed and they're not having any drainage anymore. And then on the right there, that's a daily dressing. That's what we use in the immediate post-operative period, because they do have drainage as they heal and it's more absorptive. But they should always have a dressing over the line. You can see they also have that anchoring piece that is just one extra barrier for getting the line pulled. So the more stable they can keep that drive line, the lower risk they are for getting a drive line infection, which can be very serious and can lead to death. So we want to do everything we can to keep that drive line stable and clean. And so that's what you're looking for when you look at their abdomen. Let's see. And everyone has a little bit different maintenance routine just based on their skin sensitivities or if they're having drainage, that kind of stuff. That's why it'll be different for every person. All right, so I'm going to let Jackie talk about the VAD parameters. Unless anyone has any, I'll stick around and answer questions at the end as well. But any questions of what I've covered so far?
I do have one.
Yeah.
If we see a person in VF or VT that is conscious and alert, would we shock cardiovert in the field?
Thank you for asking that question. So if they are stable, please get them to the closest emergency department and let them get some sedation in the emergency department, because these normally people would be unconscious, so shocking them is not a problem. We do cardiovert them to get them out of the rhythm, but they need sedation before you do it. So if they're stable, I would say get them to the closest emergency department so that they can, I know you can give sedation in the field too if you need to, but these patients tend to be a little less stable once they've gotten some sedation. So the most controlled environment you can get with sedation is better. So if they're alert, conscious, talking to you, or doing fairly well, I would get them to the emergency department before you cardiovert. However, if they're unstable, then yes, you can cardiovert in the field.
Would you say there's let's go with, because there's a couple questions in the chat about this, about delaying it. How long should they delay it for? Some of our services may transport like an hour. So is that long? Is that too long, or?
I would say no. I mean, that one VT I showed you, he had been in that for days and he didn't know. So people can really tolerate these rhythms for a while and do fine. If you have any concerns that you're waiting too long or you should do something, then we'll give you the emergency number. So just call us, and during the day, the VAD coordinators answer. If they can't answer your question, they will get you right to the physician. And on nights, weekends, holidays, it'll go directly to the advanced heart failure cardiologist. So they'll be happy to take your call and help you make that decision.
Great. And a follow-up to that is, how about the administration of amiodarone or lidocaine? Is that appropriate?
Yeah, we do you can use all your ACLS algorithms, guidelines. We'll talk about chest compressions here in a minute. That's the only one exception, but we do use amio and lidocaine in the hospital. You might want to, I would probably say give either your med control a call or direct to our heart failure cardiologist to make that decision whether you should go ahead with that. But yes, in general, we can use those meds.
Thank you.
Mhm.
Appreciate it. Couple comments from there is another question is, should they use the 1 milligram per minute infusion for amiodarone?
I would say use your whatever your guidelines are. That sounds right.
Yeah, that's
yeah.
Nope, that's perfect.
Anything else? All right, Jackie, are you on?
I'm here.
Okay.
I'm going to pick up where we left off. So we'll talk a little bit about VAD parameters. So what that refers to are 4 different numbers that we look at that the pump is able to provide to us to help us understand, what's going on with the pump and what's going on with the patient. So those parameters are speed, flow, pulsatility index or PI, and power. So we can go through each one. Great. I'm glad there's a picture of the controller close up. So this is the HeartMate 3 controller. So this is where you'll see those VAD parameters on that screen. The button that's all the way to the right is kind of a scroll button. So if you press that multiple times, you'll be able to scroll through the VAD parameters. Other things with the system controller, so like Lauren was saying a little bit earlier, those green arrows at the top should always be illuminated. That indicates that the pump's running. Gold standard, of course, is to listen for yourself to make sure the pump's running, but the green arrows should always be illuminated. The other 2 buttons, the button at the top is a battery button, and it does exactly that. It will illuminate the green bars that are right below it to indicate how much battery life overall the patient has at any given time. And then the button on the bottom is the alarm silence button. So patients or clinicians can press that if they are experiencing an alarm. It doesn't impact, the controller's ability to register the alarm. It just simply stops the annoying, beeping that's happening. Those other icons that you see can be illuminated depending on, if the patient's having an alarm and what type of alarm, which we can talk about in a little bit. Those crescents that are on the side on the left, those illuminate when there is a disconnect. So you can kind of see over to the left, there's a white and a black cable. Those are the power connection cables. So if one or both of those is disconnected, the corresponding kind of crescent on the side will be illuminated, which can be helpful if you're getting a beep that you can't identify where the disconnect is. That can be a helpful thing to look at. And then the one on the bottom, that is where the driveline connects to the controller. So that should never be disconnected. So that will illuminate if it did become disconnected. We can. So the first parameter that you'll see when checking is the speed. And so that's exactly what it sounds like. It's how fast the pump is spinning. It's measured in RPMs or revolutions per minute. A typical speed that we typically see is between 4,800. It says 6,000 here. I think like 5,800 is the highest that I've seen with our patients. And this is the only parameter that we can make direct change to. So, when we're talking about making changes to the pump, this is really the only thing that we're able to directly influence. Everything else is influenced by the speed and then by the physiology of the patient. The next parameter is flow, which is the amount of blood per minute that's flowing through the pump in liters per minute. A normal flow would be considered 4 to 6 liters per minute. However, there are, each patient's going to have their own baseline. There are patients, typically smaller patients or patients with, smaller ventricles who may run on the lower side. In general, what the low flow threshold would be to generate an alarm is if the flow dipped below 2.5 liters per minute. There are exceptions to that if someone has a baseline lower flow that they live with and are comfortable with. But in general, 2.5 liters per minute, if they dip below that number, it will generate a low flow alarm. Like Lauren was saying, this is like one of my favorite phrases, that we're preload dependent and afterload sensitive. So if someone's getting a low flow alarm and their flow has dipped below that threshold, it's generally because of either low blood volume or high blood pressure. Those are kind of the two common things. There are other factors that can play in, but most of the time it has to do with one of those two things. The next one is PI, or pulsatility index. So this is kind of an indirect calculation that's done by the pump. It reflects native heart contractility. It's influenced by the preload. It can be influenced by blood pressure as well. This number can vary pretty widely, even, within the same patient day to day, because it's influenced by so many different factors. And it's kind of one of the trickier numbers to really to look at, unless you're looking at it within the context of the whole patient. So we would never, just look at someone's PI and make a clinical decision based on that number alone. It's more so in the context of what's going on. Normal PI is listed as 4 to 6, but some patients live in the 2 to 3 range, and some patients who may have had recovery in their heart function may have PIs in the 9 to 10 range at baseline. So it's really patient specific, and we do teach our patients to, look at these numbers daily at home. So they usually have a pretty good idea of what their baseline is, which can be really helpful when they're calling with issues, or when, they're reporting something is going on. They're able to identify when something's outside of their usual baseline. And then the next one is power. So this is different than, looking at one of the battery gauges to see how much battery life is left. This is the energy consumption of the pump itself, measured in watts. Normal power that you'll see is between 3 to 6 watts. And like Lauren was saying earlier, the patient's baseline power consumption is going to be dependent on how fast their VAD speed is, which is going to vary person to person. So the higher the VAD speed, the higher energy consumption that we'll see. The reason why we care about this is because if we're seeing major variations in power for a patient, particularly if we're seeing power that's spiking up, that can indicate that there's some type of obstruction within the VAD outflow. So that could be something like a thrombus or a blood clot within the pump, or it could be, a twisting of the outflow graft or something going on. It's typically not a great thing to see. We recently had a patient who had power spikes, and we were concerned. We brought him into the hospital. He was having kind of a weird vibration feeling in his chest. It ended up being an issue that may have been related to some static electricity exposure that the pump was able to actually work out on its own. I can't remember the exact details, but we were concerned enough to bring him into the hospital to kind of rule out, further concern for clotting.
I do have a couple questions in the chat.
Sure.
One of the ones that came up was, does a generator or an inverter power affect these devices? So if we have generators on the trucks or inverters?
So generally you would be using a patient's batteries when transporting them. So I wouldn't think that would have any effect, if I'm understanding the question correctly.
I think that's it. And if they have anything different, they'll shoot it to us on the thing. The second one was, this might be back to Lauren again. We missed it right at the end. Should they consider life flight or another helicopter transport for longer transport versus ground for an unstable patient?
Potentially, yeah. We have patients all over the state. We had a patient for a long time in Lubec, which is, 4 hours down east from us. So I think she got flown to the hospital once or twice. So yeah, we certainly do utilize life flight if the patient is a distance and particularly unstable.
Perfect. Thank you.
Mhm.
So a little bit more about VAD alarms. So a few different reasons, three main reasons why someone would have an alarm on their controller. So commonly would be a power source issue. So that's something like, they're running low on their batteries are disconnected, or there's a loss of power. If they're plugged into the wall at home when they're sleeping, and there's a loss of power in their house, then the backup battery within the controller will take over, but they're going to get a loud alarm to let them know that they need to get out of bed and put on a set of batteries. So those are the most common, and usually the easiest to solve is connect a different power source. Low flow alarm is kind of the primary clinical alarm that we see, like we were talking about. It's the circulating volume of the pump is low for one reason or another, and it's typically a physiologic reason rather than an issue with the pump itself. Pump malfunctions can happen, but much less common than having, something modifiable that we can fix. And then system hardware malfunction, those alarms are less common. It could be an issue with the backup battery being installed incorrectly, or needing to be exchanged, or it could be something serious, in which case it impacts the ability of the pump to run. So patients and their caregivers are trained as part of their initial VAD education on, what the alarms are and how to respond to them. And it typically involves, a call to us right away so we can further troubleshoot. And yeah, I think we can go on to the next slide, maybe forgetting what's next. Any questions about VAD alarms? We don't have a ton of information in this presentation. There's higher priority alarms and lower priority alarms. The lower ones are kind of like a slow beeping, and the higher priority definitely sound higher priority. It's a constant high-pitched alarm sound. But happy to answer any questions about specific alarms. But in general, it's going to be a call to us so we can kind of suss out what's going on in any situation. Every patient should have an emergency backup bag with them, and at all times we teach them to keep it with them, no matter if they're going to the neighbor's house or if they're going on a trip across the country, they should have it with them. In this emergency backup bag, it contains a backup controller, so exact same as the system controller that they're using, but a backup in case they were to need to exchange it in an emergency. 2 fully charged batteries and 2 extra battery clips. And then whatever else they might want to have in an emergency. I like it when patients, have an updated med list in there and our emergency contact cards. But that should stay with the patient during transport, in the ED, and then if they're admitted or go home, it should not leave them.
We have another question in the chat. What type of batteries are in the device?
They are the external batteries are 14 volts lithium ion batteries, and then the backup battery is an 11 volts lithium ion.
Perfect. Thank you.
Yeah. Just wanted to list out a couple of, common complications that we see. Lauren has already talked about some of these, so I'll try not to repeat her. Driveline infection are unfortunately common. Usually they're easily treatable before they would get to the point of sepsis, but that is something that's always kind of on the radar because that driveline site is always going to be a potential source of infection. Device malfunction, like we were talking about, is not super common, but can happen. Bleeding, GI bleeding, most common. The combination of being on warfarin plus having continuous low circulation also increases the likelihood of having those arteriovenous malformations within the GI tract. So unfortunately common. Arrhythmias, like we discussed, stroke, much less common with this particular device, which is wonderful, but certainly still on the radar, both hemorrhagic and ischemic stroke. Right heart failure, so that's going to be your same types of, I mean, they would experience right heart failure the same way that you or I would. So same types of assessment for heart failure, and, you know, persistent left-sided heart failure as well. You know, this device is designed to, you know, treat heart failure and improve function, but it's not a perfect solution by any means. So we do still have patients who, you know, become fluid overloaded or have exacerbations of their CHF. Aortic insufficiency is one of the more serious potential complications from having continuous flow. You know, as you can imagine, if someone has a degree of AI that, you know, becomes substantial, it kind of creates like a closed loop circulation where blood really isn't making it all the way forward and it's backflowing and just kind of circling around, which can cause major issues. So that's definitely something we try to avoid by, you know, making sure patients have optimal LVAD speeds and their speeds aren't going too quickly to strain that valve. Pump thrombosis, less common, but can happen, like we were talking about with the power spiking. We also look out for things like Coca-Cola colored urine that could indicate, you know, thrombosis somewhere, along with, you know, if they did have a low flow alarm that we weren't able to identify another reason for, that could also cause low flow alarms. And then psychological distress, anxiety, depression, you know, it's a major it's a life altering situation. So our patients do, you know, suffer from mental health concerns as well. Emergency situations. So this is our emergency contact number. So we have our office number for the coordinator office, and then that 661-5823 or 661 LVAD is our 24/7 emergency line. So during normal business hours, that will come directly to my phone here, or after hours, will go directly to the provider on call. So no matter the time of day, if you ever are in a situation where you're having an emergency with with an LVAD patient, whether it's our patient or a Boston Centers patient, you can always call that number. Transport to nearest emergency department, yada, yada. I think that's self-explanatory. And then again, some call examples that we've had, again, kind of reflect the common complications. CPR, and Lauren, feel free to add to this too. In general and historically hasn't been recommended because of risk of dislodgement of the pump. There are ACLS protocols for LVAD patients. And I think Abbott actually put out a really nice algorithm as well that I'm happy to share if you don't have access to. But essentially, if the pump is not running, there might be situations where CPR is appropriate. But again, always feel empowered to call us and, you know, have, you know, one of our cardiologists kind of guide the situation. All ACLS drugs are appropriate. Patients can be externally defibrillated, cardioverted, like we were talking about. And the literature is evolving, so these guidelines may change in the future as well. And this is our whole team. I think that's the end.
You guys had some great questions. Normally
Yeah.
it's crickets when we present this kind of stuff. So thank you for asking, because it makes us feel like people are listening. That's nice.
Absolutely.
Anything else?
Let's see. We got the batteries questions. I think the question that was coming up with the inverter/generator is if someone has to charge their batteries off of an inverter or generator. Have you had any problems with that or anything?
I don't I don't think so. If our patients need to use generators, we generally recommend them using the generator to charge their batteries and then using the batteries versus them plugging their mobile power unit into a generator. And I'm not sure that we have any official guidance from Abbott on that specifically. Do you know, Lauren?
No, I would say if you need to use the generator in the rig, then you can do it. They don't like us like using extension cords and that kind of stuff, but yeah. But the patient, should have their backup bag with them. So they would have each pair of batteries with normal operation will last 17 hours. So if the patient has a fully charged pair of batteries in their bag, you should have plenty of power to use battery power to get them to the hospital.
I did have a request to share the Abbott algorithm if you have it. You can either, and I can share it with the group if you send it to me or however, or if there's a place that they can go find it, that would be awesome.
Yeah.
Let's see. Thank you, Dr. Bauman, for putting in the generator LVAD piece. If you're resuscitating a patient with a low flow state, is there a different max on the crystalloid than the 30 grams, 30 per kilogram? Or may you pull the trigger on vasopressors sooner than later?
So are they asking you if you would give more fluid or less fluid?
If you should switch to vasopressors earlier.
Oh, gotcha. Potentially. Yeah. I mean, these patients, are still heart failure patients. So, if they're hypovolemic and they need fluid, we give fluid for sure. But we're just a little bit more conservative with our fluid boluses and just making sure we don't go the opposite direction and overload them. So I think potentially if you've given fluid and it's not working, then yeah, that's appropriate.
And final question of if they need to get med control, who would be the best people to call?
So I guess I don't want to say the wrong thing as far as what the protocols are for EMS in Maine. It's never wrong to call our cardiologist and use our emergency number and get our input because we know these patients so well. But as far as med control, I would defer to your protocols.
That makes sense. Let's see. Yeah, and that was what it was should they call an ED provider or an LVAD team member to get that piece? Probably sounds like they should start with the coordinators first and work their way to the ED.
Yeah, generally, I just think we're well prepared to answer your questions because we've worked so long with these patients. We're going to know their history and what meds they're on and everything else about them, and plus the bad experience. So I guess I would always support giving us a call, but med control is a great resource as well.
Awesome. And if the patient's not a MMC LVAD patient, but they call, will you give them help?
Yes.
I thought so.
Yeah, we can troubleshoot any VAD. We just won't know as much about the patient history, but as far as equipment and that kind of stuff, and if it happens to be a HeartMate 2 or a heart device, we can help with those too.
And this one may actually be a question for Dr. Zimmerman if she's on. Can the provider take direction from the coordinators and the other people if it's within their scope?
I would say certainly start with the coordinators or who we're going to reach out to.
Right.
If it has to do directly with the function of the LVAD. But in terms of like medications and whatnot, they should also get online med control online because technically for orders for medications and whatnot needs to come from a designated either physician or APP that's trained. So I'm just not sure background wise. I missed the very beginning. But I would certainly be reaching out to them.
Perfect. And yep, and Pat put a great comment in there too, that if you have a Boston patient, they also have coordinators from Boston that can assist those people also.
Yeah, most programs, the patients will have like the emergency contact cards in their bags or should have them handy in their phones or whatever. So you could reach out to the Boston programs too.
Awesome. Well, we truly appreciate your time.
Yep.
It's been quite informative also. I really appreciate it.
Great. Thanks for having us.
Thank you.
Thank you all.
All right, thank you. Good job.